Welcome. Welcome to Unequal Care, Mental Health, and Black Americans. I'm Linda Rosenberg. I'm on the faculty at the Columbia Department of Psychiatry, and I'm moderating today's conversation. And we're very fortunate to be partnering with the School of Journalism here at Columbia. We're going to be together for about an hour. We are recording the session, and I have three tasks. I'm going to say a few words about the origins of today's conversation. I'm going to introduce our very special panelists, and I'm going to ask questions, including questions that come in the chat box. But before I start asking questions, let me answer a question we got from a registered viewer. Why Columbia for this conversation? Why the topic of mental health and Black Americans? And why am I moderating? First, we're all experiencing two pandemics, the COVID-19 pandemic and its devastating effects on communities of color, and the pandemic of racial injustice, a long-standing, persistent pandemic of brutality against Black people. Second, academic medical centers like Columbia expect to be regarded as sources of truth and leadership. But that status can't be assumed, it has to be earned. We can't lead without acknowledging that racism makes people sicker and makes them die sooner. Third, with the leadership of our chair, Jeffrey Lieberman, Columbia wants to translate anti-racism rhetoric into core values and, most importantly, into actions in clinical practice, education, funding, and research. And finally, although I've not experienced racism, like many who are listening, I'm an avid learner. And I'm honored to be moderating, and I look forward to learning from our panelists. So without further ado, I want to introduce our panelists. Two of whom I know, one for quite some time, and the third who is new to me, but I'm very honored to have Dr. Brian Smedley with us, who is really a thought leader in the field of health equity. He's dedicated his career to reducing our nation's health disparities. I'm actually reading a brief bio because I couldn't memorize them all. He's the American Psychological Association's Chief of Psychology in the Public Interest, and he's Acting Chief Diversity Officer. From 2008 to 2014, Dr. Smedley was Vice President of the Joint Center for Political and Economic Studies. Previously, he was co-founder of the Opportunity Agenda, which builds the national will to expand opportunities to all. Dr. Angela Coombs is a board-certified psychiatrist at the New York State Psychiatric Institute and an instructor in clinical psychiatry at Columbia University Medical Center. Dr. Coombs is the medical director of On Track New York, Washington Heights, which serves young people experiencing their first episode of psychosis. She completed her residency here. She was in the Public Psychiatry Fellowship here, and she was a chief resident. She was awarded the American Psychiatric Association SAMHSA Minority Fellowship, as well as the American Psychoanalytic Association Fellowship, where she studied intergenerational transmission of trauma, and we've been talking lots about trauma as well as resilience. In addition to On Track, she works in Columbia's psychiatric ER, and she has a private practice in Upper Manhattan. Dr. Sidney Hankerson is co-director of the Columbia University Wellness Center, assistant professor of psychiatry at Columbia University Medical Center, and a research scientist at the New York State Psychiatric Institute. His research focuses on increasing access to mental health services in communities of color. He's been featured at many conferences, including the White House Dialogue on Men's Health, where he appeared after publishing the first ever depression screening study in African American churches. He was appointed to the American Psychiatric Association Council for Minority Health and Health Disparities and the APA Council of Faith and Community Partnerships. As a clinician, he provides direct care to patients at a federally qualified health center in Harlem. Of you, and if you don't mind, I'm going to use your first names for the questions. So I thought what we would do first is get to know each of you a little bit. And if it's okay, Brian, I'd like to start with you. You've dedicated your career to racial justice. How did that focus begin and how did it evolve? If you'd briefly share with us.
Sure. Well, first, thank you so much for organizing this panel and this very important conversation. I have been focused on understanding race, understanding racism in America since my graduate school days as a trainee in clinical psychology at UC. I wanted to apply the tools that we are trained in scientific methods of psychology to apply our tools to the societal issues. And racism is one of those issues that sadly has been evergreen throughout my life and has deeply impacted me, my family, my community, and all of us. So it is easy to understand that if we can address racism, which is one of the deepest and most profound inequities in our society, it will be easier to begin to address some of the other destructive social hierarchies in the US.
Thanks, Brian. Angela, can you briefly talk about your work, including the Public Psychiatry Fellowship and now your commitment, unfortunately, to young people, or fortunately that you're committed to it, but young people who are developing serious mental illness?
Sure. Well, I also want to just start by saying thank you, because I think anytime we take time to center and affirm the humanity of Black people and our well-being, it's a special time. So I'm really grateful to participate tonight. So as far as the evolution of how I got to where I am now, I think I always had a certain enthusiasm at the outset of training around thinking about being around a certain kind of healing work in mental health and being a psychiatrist. But at the same time, was also holding, early exposure to the reality that just psychiatry specifically, but medicine more broadly, just the structures of care have not met the needs of a myriad of people. So in my training, I was very hungry to be exposed to experiences that showed me alternative ways of care, like anything that really met the needs of folks that traditionally were unmet. So that could be from as sort of small as a particular clinical encounter where I saw somebody really feel that and believe that there is such a thing as mutual expertise when there's two people in the room, not just one expert, and how that showed up and how people collaborated and worked together. So fast forward into when I was a public psychiatry fellow, I had the opportunity to have my site placement on Track New York, as well as Inwood Clinic. They're both under the Washington Heights Community Service. But it really was an incredible experience to get exposed as a trainee to this setting, because traditionally the model for psychiatry is like we're taught to elicit a history, to discern and figure out what kind of symptoms people are experiencing, to have a sense of what the strongest evidence-based treatments are, and to make recommendations based off of that, and then to monitor for like symptoms and side effects. But the challenge with sometimes that model is that the symptoms sort of become the North Star, right? So it's like, are we having a reduction in the, frequency of the voices you might be hearing, or anxiety? But at On Track, especially because a lot of young people can be very ambivalent about the diagnosis they might have heard from somebody else is telling them what they have, that it's an opportunity to say, you know what, let's just actually shift what our focus is to what would feel most meaningful in your life. What would be a life worth living for you? Is it, getting that first date with the person you had a crush on for the last 6 months? Is it going back and finishing high school? Is it getting that, PhD in Afrofuturism? Whatever it is, let that be our North Star, and then have a whole team that works collaboratively to help make that to be, you're like shipmates and you're the captain of your ship. And it's a very special environment as a psychiatrist to be on a team like that, because my job and my task is to make sure that the medication is supporting somebody in those aims and not getting in their way. Because oftentimes for folks with this particular types of vulnerabilities, medications can be getting in their way of actually doing life in a meaningful way.
Thank you, Angela. That was quite inspiring. Sidney, much of your work centers on collaborations with churches. How and why churches particularly?
Well, thank you, Linda, for that question. I'd first like to echo Brian and Angela and just thank you for moderating and thank Dr. Lieberman for creating the space for us to have this panel today. So why churches? Well, my faith has actually been a very important part of my life since my childhood. My father is actually a deacon in my childhood church, a predominantly Black Baptist church in a small town in Virginia. And my mom actually played the piano for the little kids choir. So I was in church at least 2 days a week growing up at choir rehearsal and then on Sunday service. And then as I actually did my psychiatry residency at Grady Hospital in Atlanta, I realized how frequently patients would talk about the importance of their faith in their treatment. And I often realized that there was sometimes a kind of a disconnect or a conflict between people's religious views as well as kind of psychiatry's views towards religion. And so when I came to Columbia in 2009 to do a research fellowship, I knew that I wanted to focus on reducing racial disparities in depression treatment. And one of the first works that I read was Dr. Smedley's truly seminal work on unequal treatment, where we saw the breadth of racial and ethnic disparities throughout the gamut of the healthcare system. And in trying to address and think about multi-level interventions to address disparities, I saw that churches had been successful in addressing some of those disparities, but there was a limited amount of literature in church-based interventions to address mental health. And so building on my own personal experiences and then turning to the literature and understanding that churches, especially in the African American community, are kind of de facto mental health clinics, that was how and why I decided to partner with churches to increase access and promote mental health equity in the Black community.
Thanks, Sidney. Thanks so much to all three of you for sharing with us. Let's talk about COVID and its impact just for a minute. Angela, with Black and Latino people 3 times as likely to become infected as whites and twice as likely to die, you wrote a New York Times letter to the editor. And in it, you said, and I think I'm quoting correctly, though the virus may not be racist, structural inequalities, the sturdy products of racial discrimination, shape health outcomes. Can you describe those sturdy products? And then Brian and Sidney, please feel free to weigh in.
Yeah, sure. What I was trying to sort of get at in that letter was the reality that racism has come to shape the very fabric of American life, from who is able to get a mortgage loan at what interest rate to who gets surveilled and criminalized for a particular kind of behavior. And that sort of the amalgamation of the ways in which racism is baked into the very fundamental institutions as a part of American society shape and drive outcomes. And I found, one of my favorite definitions for racism comes from Dr. Camarojones, and I find her work so incredibly helpful in making sense of what we bear witness to on a day in and day out basis within healthcare and then more broadly in public health. But she talks about racism as being a system of structuring opportunities and assigning value based off of the social interpretation of how someone looks. So that's what we mean when we say race. It's the social interpretation of how someone looks. And so, she goes on to talk about how that unfairly disadvantages some and unfairly advantages others. And I just think it's so important and really challenging still for folks within healthcare who I think, not a week goes by where we don't see a study published that talks about race as a risk factor for something, like if it's individuals Black, then they're more likely to X, Y, and Z. But rarely do you see within healthcare us calling out racism, actually, not race, not the social interpretation of how we look, but racism itself, and exploring that. So I wanted to amplify that and my concerns about the vulnerabilities of Black folks, and particularly with anti-Black racism and its how vast it is within this country.
Resonate for you, Brian, Sidney?
Absolutely. Dr. Coombs, that was great. I'm a fan of Cora Jones. She nails it. And Kamara says racism is in itself a system. So already we're seeing a heightened awareness and the about systemic racism, which is an that individuals, of course, contribute to the problem, but individual behaviors and attitudes are not the limits of the problem. I think Kamara would agree that, as we unpack racism further, we can understand it operating at least 4 levels. One is structural forms of racism: laws, policies, practices, customs, cultural narratives that maintain a myth of white superiority. And so, of course, today, laws prohibit discrimination per se, but they don't correct the historical injustice in the first place. So a perfect example of structural forms of racism is residential segregation. It was enforced by law and policy and practice and custom, and it maintains segregation today. The 3/4 of communities that were redlined in the 1930s and 40s remain overwhelmingly people of color neighborhoods today, and they remain overwhelmingly poor neighborhoods because of the original injustice of denying investment in those communities. There are institutional forms of racism: policies and practices of healthcare systems, educational systems, criminal justice systems, where we see racial inequities at every step of the process, and understanding that policies and practices of these institutions are, of course, neutral with respect to race, but they nonetheless lead to racially disparate outcomes. And so those are institutional forms of racism. We're all more familiar with I'm sorry?
We're going to look at some of that in mental health itself, because I think we often look externally and look much less at ourselves.
That's right. We're, of course, all familiar with interpersonal forms of racism in terms of specific acts of racial hatred and discrimination. Sadly, in this era, we're seeing a resurgence of overt expressions of racism because of the political climate, and internalized forms of racism, understanding the deep damage to the mental health and well-being for marginalized populations of living in a racist society. So all of these forms of racism taken together lead to a cumulative health disadvantage for Black and Indigenous people in particular.
Sidney, anything to add?
Yeah, I'm also a huge Camarojones fan, and I think that for those who have not read her 2000 article in the American Journal of Health that really specifically outlines and defines racism according to those levels that Brian just articulated, it's an excellent read. And I'll just conclude with kind of a personal anecdote about how systemic racism has impacted, my life. So my mother grew up in Aiken, South Carolina, small town in South Carolina. And at the time that she was born, Black adults were banned from delivering babies in hospitals. They were banned from getting prenatal care, banned from giving birth in hospitals. So Black adults had to give birth in homes. And as you can imagine, lack of access to prenatal care, lack of access to emergency medical services if needed, contributed to a tremendously high infant mortality rate. And although my mother was the first of 7 children who were born, 3 of my grandmother's children died before they were actually 3 months old. And so that is an example specifically of how systems were created to prevent Black folks in this country from access to medical services, and it has devastating, health outcomes.
Well, it's being predicted. Let me ask another question. I keep hearing we're going to see a tsunami of mental illness as the result of COVID. First of all, do you agree, just very briefly? And then if you do, is it going to particularly affect people of color? One of you want to tackle that?
Well, I think absolutely. From our vantage point, there is a huge unmet and growing need for mental health services, a coming mental health crisis as a result of the pandemic, but of course, all of the conditions that have been associated with it: economic anxiety, fears of or transmitting the virus. And of course, disproportionately, Black and brown people are working in jobs that increase risk for exposure, in some cases with little in the way of personal protective equipment. So those are just the things related to the pandemic itself. Of course, the pandemic has also brought with it a huge torrent of race phobia, other expressions of intolerance that create a broader climate that is incredibly stressful. APA, American Psychological Association, releases a Stress in America survey. We found that 55% of African Americans report having high levels of stress in this period of COVID. And so clearly, we face an enormous challenge. The problem, as I'm sure we all know, is that the mental health infrastructure, particularly for people of color, is wholly inadequate. We have not invested in the resources necessary for public health care, behavioral health care. And of course, that compounds the challenges that many in Black and brown communities face in terms of trying to access needed services. So we are unfortunately going to reap the consequences of that lack of investment, but we've got to start planning now to mitigate the challenge.
I want to ask a question about grief. We've seen, the dying, and we've seen people dying alone. We've seen, families not able to be in touch. In fact, I know some of the residents here who were working in the ICU actually were trying to connect people via iPad to say goodbye. But we've not at all talked very much about how we're going to deal with that grief, both individually and collectively. Angela, Sidney, do you see it in your practices, and do you have any thoughts about what we might start to think about doing?
I think absolutely. I think, I have sort of the opportunity of working in multiple settings and across the board. I think people are grappling with so much and grappling with a lot of loss. And the part of the challenge as it relates to the COVID-19 related restrictions is a complete disruption in usual ways of being able to mourn and process in community. There were already processes disrupting, people being able to exist in fully in loving community. But nevertheless, there's still tremendous resilience and ways in which people overcome obstacles and barriers. So I want to also give voice to that, but there's just so much at once. I think one thing, and to Dr. Smedley's point, I think we have an opportunity to really not only think about how we pour resources into the healthcare infrastructure, but about all the other things that promote health and well-being for people outside of that traditional model. So, I know that Sidney will be able to talk about work with the churches and whatnot, but there are so many places where people go for healing and to reorient themselves and for wholeness that's outside of the hospital and outside of the clinics. And that's
I like
super important
that.
to elevate.
And you know what it makes me think of is, Dr. Smedley, Brian mentioned people of color working in essential jobs. What can we do in those kind of workplaces as well? And we recently, honored 9/11, and, we with the victims and heroes, and it made me start thinking about collectively, what will we do post-pandemic? Any thoughts, Sidney?
Well, I definitely, Linda, want to touch on the point about grief. And I think that grief has hit the Black community in two waves, as you alluded to earlier. First, there was COVID-19. And then, of course, with George Floyd's murder and the awareness, increased awareness about police brutality, that just sent a shockwave of trauma, throughout the Black community. And I think one of the challenges of COVID is that because of social distancing, people have not been able to congregate in churches, and people go to pastors for support around grief and depression in the African American community more frequently than they do to seek care from psychiatrists. And so, because of COVID, I think a tremendous amount of that social support has been lost. And so, actually, this issue around grief is one that I'm particularly interested. And I've formed a relationship recently with Kathy Shear from Columbia's Center from Complicated Grief. And she and I are working together with our main church partner, First Corinthian Baptist Church, to try to think of a replicable model of supporting folks, be it either virtually or training pastors of how to support grief, as well as specifically understanding how racism contributes to grief and loss in the Black community. So it's an especially important issue.
It is, and so let's talk, about George Floyd and really the reckoning that we are coming to terms with in terms of racism. And I want to look specifically at mental health because, as I said earlier, it's easy to look elsewhere, not so easy to look at ourselves. And when we look at mental health, Black and people of color are more likely to be hospitalized and institutionalized. White people are more likely to get outpatient treatment. When I was with the Office of Mental Health here in New York State, and we looked at our secure units, they were filled with young Black men. Do any of you have any thoughts about how we begin to track what's going on in mental health? And what we might do about that and own our own problems? Sidney, Angela, Brian?
Yeah, so I'd love to start with this. So I think that, the disparities that you talk about, Linda, are well documented. We know that African Americans with depression, my focus is depression, are more severely impaired, are sicker longer, and have more treatment resistance compared to depressed white Americans. And we also know that Black adults with depression are more likely to be hospitalized, as you mentioned, compared to receiving outpatient treatment. And so I think that the causes for that are multifactorial, including lack of access to insurance, lack of trust with mental health practitioners in general. I think especially for Black men with psychotic symptoms are more likely misdiagnosed as having schizophrenia compared to white men with psychotic symptoms, or more likely diagnosed with bipolar disorder with psychotic features or major depression with psychotic features. So I think it's important for us as mental health professionals to own the part that we've played in contributing to these disparities as well. The way that we've tried to address some of this is by, instead of maybe the traditional medical model of expecting people to come to us and sitting in our offices, we've tried to go out into the community by engaging faith-based organizations, by engaging barbershops, by engaging hair salons, for youth, engaging schools, and really engaging families to try to meet people where they are. And this task shifting approach of training kind of trusted peers, trusted community members to be able to identify, support, and then connect people to care. I think that has been one way we've tried to address some of those disparities.
Let me ask a question about addiction, because we, talk more about mental health usually than about addictions in settings like this. When cocaine and crack were the epidemic, we had mass incarceration. The opioid addiction, has led to increased treatment. Has any of those treatment dollars flowed to communities of color? What's your sense of that? Dr. Smedley, Brian, any of you?
Specifically, but yeah, clearly, part of our challenge is understanding how we've criminalized addiction issues as well as mental health issues, and particularly so for Black and Brown. So if the criminal justice system is the first place of contact for a person in need of addiction services, then clearly we have done a deep disservice and need to be rerouting dollars, absolutely.
I think this actually also connects with your previous question too, because it's so important to hit home the point that overall, Black Americans with mental health condition. SAMHSA has this data that shows that less than 30% of folks, Black folks with a mental health condition, will have engaged in any mental health service in that last year. But we actually are overrepresented in the hospitalizations as well as involuntary hospitalizations. That's huge. So you take the fact that people already are having limited access to services, but over like extended access to hospitalization, which is thought of as our higher level of care, right? Sort of the ICU of our psychiatric world. And so it's complicated in the fact that people are being involuntarily hospitalized at the rate at which they are. And it's analogous to what we see in when it comes to thinking about substances. So when we have data that shows comparable use of marijuana, but 4 times the likelihood of somebody having a marijuana offense if they're African American. So we can't think that our system isn't also in many ways criminalizing or surveilling or being coercive of Black and brown people. I think it's also important to emphasize too, because particularly thinking about, I talked about the work in first episode psychosis, but not only do you have folks being overdiagnosed with primary psychotic disorders, which really relates to an underdetection of mood symptoms, an underdetection, but you have people more likely to be placed on first generation antipsychotics, which are associated with certain side effect profiles, more likely to be placed on more than one antipsychotic, which increases side effect burden, which has all kinds of sequelae down the line. You also have people less likely to be given, first, what we think of as some of our golden standard treatment for folks who have failed other trials of medication, such as clozapine. So really across the board, we see that there's a difference in our treatment when it comes to Black people. And there's so much that needs to be rectified when it comes to that.
Angela, I would challenge Columbia, and I think we need to start counting that, and to really look at ourselves and what treatment people are getting. I started this by saying we wanted to take action and not just have anti-racism rhetoric. So I think this is an area we can begin to think about. What do we want to monitor? Because what you count is what you do something about.
And the important thing,
no, go ahead, please.
I was just going to say, and to avoid the temptation of it only being thought of as on the individual level intervention, where you're like, okay, I'm going to use, and it's good to use scales and try to challenge some of your biases, do your, implicit association test. That's all good stuff. But I think that it can be tempting to almost miss some of the institutional aspects of some of these outcomes that we see. Jonathan Metzl in his Protest Psychosis book speaks specifically about during an era in the 60s in which the conceptualization of schizophrenia was shifting. You have a time where between the iteration of DSM-1 and DSM-2, you go from this gender neutral description of, this particular reaction to schizophrenia, and a type of schizophrenia being defined as paranoid and explicitly male, like using literally, gendered pronouns. So there are real ways in which people started fitting the criteria for that were literally protesting and trying to affirm their humanity and human rights, but it was conceived of as being paranoid. And
that would be another panel for us to think about, right?
And I just want to add to the point, Linda, about opioids. I don't know if most people know that in New York now, in New York City, more Black New Yorkers are dying from opioid overdoses than white New Yorkers. And so this is a fact that is not commonly known. And part of the reason is directly related to the point that you made, that a lot of those treatment dollars are not filtering down to communities of color. Another reason that that's happening is because of the rise of fentanyl. So fentanyl, which is a synthetic opioid, is much more potent than heroin. And so there's a tremendous need to increase awareness about opioid overdose deaths in the Black community, because so often it was presented as just a white disease that was happening in the suburbs,
right.
But actually it's evolved. And so I'm very happy to be working tomorrow morning. Myrna Wiseman and I have a meeting with Jermaine Jones and Sandra Comer to talk about ways to address opioid overdose in the Black community in New York.
Good, that's great. In a New England Journal of Medicine point of view piece, Dr. Kevin Gutierrez called out new anti-racism curricula. He fears, and in quotes, anti-racism curricula may distract us from the very institutional problems that got us here. Until anti-racism is seen not merely as new information, but as a continual practice of unlearning, it joins a long list of actions that have only delayed examination of institutions themselves. What do you see happening, related to his statement? Are changes starting? You're all, in the inner circle of psychiatry and psychology. What's going on in some of those institutions of learning and training? Any thoughts? Any information?
Well, Angela and I actually are members of Columbia Medical School's anti-racist task force. So when I saw that question, I was intrigued. As co-chair of the task force, I'll try to be as unbiased as possible and not try to take a personal attack to the question. So I do want to put that disclaimer, out there. And I'll let Angela share her perspectives as well. But, Columbia's anti-racist task force for the medical school is charged with creating and addressing racism on 4 levels. 1 within admissions, 2 in curriculum, 3 within student supports, especially a focus on mental health supports, and then 4 within the learning environment. And so, as co-chair of this task force, I'm really trying to encourage our members to think about how we can think about this on an institutional-wide basis and not put the onus on the students, especially those Black and Brown students who often feel the burden of minority stress and being the only ones to have to speak up about issues of racism, but really hold the faculty and the institution accountable so that we can make sweeping changes throughout the university. So that's, at least my hope with the task.
You represented the committee very well. Angela?
Yeah, I think what Dr. Hankerson is talking about in this task force is exactly the kind of thing that we need. We were talking about actionable items. And, definitely shout out to Kevin Gutierrez at NYU, because he was a June Jackson Christmas scholar at Columbia, which was a program started by Patrice Malone, who's a PI grad and child adolescent psychiatrist, who created this program as a resident to increase the pipeline of underrepresented folks within psychiatry. But he's making a phenomenal point, which is that a lot of times people approach this as like more learning to be acquired, like it's some intellectual endeavor, when the reality is that there needs to be action. So he really calls for us to really examine some of the hypocrisy around spending time learning and talking, but not in the doing. And I think it's really, really great for us to be able to see that, like a task force such as the one that Dr. Hankerson is co-chairing, to be able to be looking at actual items and saying, how can we move the dial forward?
Brian, from psychology's point of view, are you seeing anything change, any action?
In psychology, we've always had an emphasis on continued learning around equity, diversity, and inclusion principles. And so fostering that kind of thirst for lifelong learning is what's most important. But I also totally appreciate and say amen to the action piece and the need to deeply understand how our institutions have contributed to inequity. There are so many things that institutions have that can do with a little creativity, including members of the community on admissions committees, for example, and other advisory roles. The continual process of learning and holding our institutions accountable is important. And we have yet to completely understand that institutional accountability is as important as academic rankings.
Yeah, that's an interesting point about measuring it the way we do rankings. I have a question, something that's been a pet peeve of mine for the last few years, ever since it's become this kind of theory everybody is talking about, social determinants of health. Now, I know that social determinants affect all of our health, But when it comes to racism, do we sometimes use it as kind of a euphemism for poverty, for racism? Talk to me about social determinants and how we separate what we all have as our social determinants from racism's impact on health.
Absolutely. It's encouraging to see health professions, educational institutions thinking about and talking about the impact of social determinants of health, environmental, social, economic factors that we know powerfully shape health. And if you think about the old McGinnis and Fagey model of the relative contributions, social and economic and environmental factors could contribute up to 60% of a person's overall health status. We have to understand, though, how environmental influences are fundamentally different for many people of color because of things like residential segregation and our history of environmental degradation in communities of color. The fact that communities of color are disproportionately food deserts. This, of course, goes beyond mere issues of poverty and helps us to understand truly the Jones definition, which is how opportunity is structured along lines of these social categories. So we are, in fact, structuring opportunity when the social determinants are incredibly and disproportionately aligned against people of color because of the foundation that racism sets for influencing all of those social factors.
Angela, Sidney, any additional thoughts, or can I go on to another question? We're starting to get some questions coming in, and I want to get to those as well, if that's okay. But before I do, there was a 2018 report from the American Psychological Association, which said only 4% of therapists are African American. The data is worse when you look at CEOs of health and behavioral health organizations. And I'm of the belief that what the CEO is interested in is what gets attended to. Given the issues and the very things you've talked about, redlining, we haven't talked about schools. I just had an interesting conversation. The PTA in Park Slope, where my grandchildren live, raised $800,000 for 1 year, and they've been able to hire some additional teachers as a result. In Brownsville, the PTA was able to raise $2,000. So again, the race, the structural inequities are just enormous. Any thoughts about how we begin a pipeline earlier on in the professions so that we have more representation of the people we're treating and serving? Brian, you're nodding your head. Do you want to begin?
Sure. This is a challenge that we absolutely have to rise to. It is clear that with a population that is growing more diverse by the day, that our professions have to reflect the communities that we serve. And so what we ultimately need is comprehensive reform in terms of how we value young children of color, starting early with home supports, nurse home visitation programs, high quality early childhood educational programs. We know from piles of evidence that these have long lasting benefits and increase participation in higher education among young children exposed to these early interventions. Then obviously our K-12 public education system is deeply inequitable. Our schools are now more segregated today than they were in 1954 when the Supreme Court ruled on the Brown versus Board of Education decision. The problem behind that is that schools that kids of color attend are chronically underfunded. Teachers lacking credentials to teach the subjects they teach, outdated textbooks, etc. Again, we've lacked investment in young people early. But beyond that, what can we in the health professions, education's institutions do? Dr. Hankerson referenced admissions policies to the extent that we can move beyond testing, standardized testing as a factor in admissions, understanding whole file reviews of applicants, revising our admissions practices so that we're more responsive to the communities that we're ultimately serving, including, as I suggested earlier, having members of the communities that we serve on admissions committees in our medical schools and nursing schools and so forth. Accreditation, of course, also plays a significant role in encouraging diversity and inclusion efforts on our campuses. So in my view, it has to be comprehensive, starting early, valuing children of color for their talents and what they will bring to our communities, and then providing supports necessary to overcome generations of structural disadvantage in their subsequent educational years through their highest level of educational attainment.
And I also think that at the other end of the pipeline, we still have to confront the reality that you have many places in behavioral health organizations in which there might actually be underrepresented folks present, but there's that ceiling above in which people aren't making that next promotion or having that opportunity to have more influence and impact on particular programming or services. And so there's still the need to reckon with that. And a lot of times people believe that historical perceptions about and notions about Black people, or racist notions about Black people, such as communities who can't manage themselves, or need to be guided or need to be monitored or whatever. Oh, that's historical, but it's actually the contemporary issue, because you still have people with a tremendous amount of expertise who people in organizations still feel like they need to have to monitor them and have to manage and so on and so forth. So there is the entire pipeline. The early really matters, right? So if you want to have it as wide as possible, and still also paying attention to the fact that there seems to be a threshold, which, because you asked specifically about leadership, a threshold which is hard to traverse.
In behavioral health, it appears to be middle management. That seems to be the ceiling, and you don't see people being mentored and really being lined up as the next cabinet member or executive team member. So I think that's another area where we need to look and start to count ourselves.
Can I just add, Linda,
yeah,
because during your leadership, and I know this, I am, went to the National Council conferences.
An old friend.
Yeah, exactly. But I think, did a tremendous job in leading that organization and addressing that gap for middle managers, and created a pathway of mentorship, support, and advancement for managers of color that I think should be replicated, especially in academic medical centers. So I think that is so important.
It has to be intentional, Sidney.
It does.
It doesn't happen by accident. And one of the amazing thing was when our vice president, really for talent, human resources, became a woman of color. And I have to tell you, that made a difference because resumes, people see names and they're not even thinking about it, but they're automatically rejecting some and choosing others. And so I think you want to have diversity at the highest level and be very, very intentional. We have a question from someone listening in. Police respond to psychiatric emergencies, and we've seen the resulting deaths. Several cities have piloted sending mental health people out on psychiatric emergencies, and now there's a national discussion and advocacy movement. What do you all think about that? When I have heart trouble, the police don't come. And so should we be thinking about that in terms of people with psychiatric emergencies?
Yeah, I think that in New York in particular, we've had to bear witness to this in a very tragic and gut-wrenching and heartbreaking way by the events over the last few weeks. And so I do think it would be tremendously helpful to have mental health professionals go out on these calls, specifically when there's an issue around a person who has a known mental health condition. I'm not aware of the data of the effectiveness of some of those other pilot programs, but I do think that it would be helpful.
Yeah, and just to echo that, I think that it's it really is meaningful and important to have clinicians be able to be there to manage crisis, right? For somebody experiencing a mental health crisis, it's not the sort of, it shouldn't be the role of a police officer who's supposed to be managing crimes or whatever else, to be there for somebody who's in a mental health crisis. So it is kind of a great sign to see people really trying to fund and support a movement to bring this kind of care back into the therapeutic modality, right? Back into an environment or an engagement that is really supposed to be therapeutic. I'll just say that, sometimes programs get developed and it either has like a mental health specific focus, or there's some training as it relates to anti-racism, but it really needs to be integrated together, because we know that the outcomes for folks who have serious mental illness and are having a particular crisis are worse, than even for white populations. So we really want to make sure that these are integrated together.
And another question we have, Sidney, specifically for you, is there's been a 73% increase in suicide attempts among Black boys. Any thoughts about what we should begin to focus on and think about?
So this is actually one of the great public health issues of our time. And I was on a call yesterday with Michael Lindsay from NYU, who actually published that article. And so he and I are actually planning to submit a proposal together to try to address this issue. I think what we know about the increase in Black suicides is that in white youth, there seems to be a predictable pattern of distress to self-injury to suicide attempt and perhaps completion. In Black youth, that predictable pattern is not there. And so it really speaks to, I think, the lack of engagement that Black youth have with traditional medical and mental health services. And really, we need to understand what is happening in between. The stressor, a lot of it has been connected to cyberbullying and social media, but there's so much that we don't know, and that it is truly a public health, crisis of our time.
Heartbreaking. We have another question. It seems like the American Medical Association, the American College of Emergency Physicians, and the American Psychological Association have declared institutional racism as an urgent public health issue and made a declaration about that. Brian, can you talk about how that came about at APA, the big APA, I have to say?
Sure. Well, thank you. It came about as a recognition that clearly racism is a public health crisis, and it is a public mental health crisis as well. So understanding the depth of this problem, of course, racism has been a persistent part of the landscape in this country for 400 years. But what has been, I think, compounding the challenges and making this era more complicated is the current political environment, and the fact that unfortunately we have given new voice to voices of hatred, and rather than marginalizing those voices as we have been previously. So clearly racism remains a key risk factor. And as we've talked about through the many examples that this wonderful panel has provided, many examples of how racism has damaged not only opportunities for health and well-being for people of color, but also efforts to mitigate and heal the problems that emerge. So I think as a starting point, we at least ought to emerge from this crisis with a much more comprehensive plan to support a robust mental health infrastructure that is responsive to the needs, particularly of populations that are most marginalized at this time.
Let me push back a little bit on that, Brian, and Angela and Sidney weigh in. When you say a more robust infrastructure, we all agree, but what does that mean? What should we actually try to do next? Because we have a myriad of services, right? And there's, a new flavor of the month, a new initiative by some foundation. Everybody wants to, have something shiny and new. What do we need to change?
Yeah, and that's the challenge, is that there are so many ideas and different camps, and I'm not going to side with any of them, but I do think that it starts with an understanding that clearly mental health services are trying to address the same challenges as public health and other clinical services. Understanding the needs of a whole person, mental, health-wise, spiritual, and understanding community context will be critically important for any effort going forward.
I'll also say,
Go ahead, Angela.
I really strongly believe that a way forward as far as being innovative and addressing people's needs is to have people with lived experience at the helm. We really need people in leadership who have a lived experience, whether it be navigating psychosis, navigating depression and anxiety, like overcoming structural barriers and structural obstacles. I mean, people do this. There really is a tremendous resilience and creativity amongst the many diverse people that exist within Black communities, but it's so like not tapped into. So I think it's really important to amplify. We see great examples of folks that are doing this kind of work. There's an organization called Beam, for example, that's really centering the health and mental well-being of Black people, a coma project. There are people out there doing this, but we need to be able to magnify folks and to have the resource and leadership to be able to make the change that we want to see.
So that could be something else we could challenge ourselves to in Columbia, right? Is knowing those programs and then seeing if we can connect them to people who can spread them in some ways.
Yeah, I completely agree with that. And I completely agree with, Angela's comment about really having people with lived experience and those from the local community being leaders in this initiative. All of the work that we do in partnership with churches and other community-based organizations uses principles of participatory engagement, community empowerment, and with the goal of actually letting community members lead, telling us what matters most, telling us where the resources need to be, and most importantly, telling us what are the unique strengths of a community and what are the assets so that we can enhance and strengthen them instead of focusing so much on a deficits-based approach.
Other than churches, do any of you have some other thoughts about community organizations that we've, not really tapped into their leadership? Are there other groups? Is it WISE in communities, YMCAs, YMHAs? I mean, are we doing enough with the natural organizations of communities? And what are we going to do online? Because so many young people are spending almost all their time on social media.
I think there are other trusted institutions that we could partner with that are already doing things and thinking about things as it relates to the mental health needs of Black folks. But HBCUs, mosques, there are a lot of other sort of places in the community that have already garnered and have built relationships, are part of the very fabric of certain communities that we could be partnering with.
We have a question for you, Angela, and we only have a few minutes left. Someone had sent in a question last month. An editor at Black Enterprise wrote about how growing up therapy was stigmatized in her community. And when she finally went to see a therapist, she did so in secrecy. And she connected the stigma to being taught that you needed to be tough to survive as a Black woman in our world. Do you see that at all among, the people you treat and also the people you know?
Yeah, I would say absolutely there is a lot of stigma, but I think it's so important to contextualize that stigma. The stigma is not ahistorical. So you can imagine with the legacy of racial subjection from, time of slavery, Jim Crow, to contemporary issues that face like Black American life today, that if you imagine there's this narrative that Black people are defective or pathologized or so on and so forth, it is tremendously difficult and it might not feel that adaptive to actually say I might have experienced some vulnerability as it relates to my mental health. The irony of it is that, in fact, to affirm our full humanity is actually to really recognize that we have strengths as well as vulnerabilities, not unlike any other human, population group on the face of this planet. So I think a lot of the work that I do individually with folks is to unpack some of that, internalization of that stigma, which actually occurs on the axis of so many different parts of people's lived experience, not just as it relates to the racialized or minoritized experience, but their sexual experience as being a sexual minority or gender minority, and it really runs the gamut. So that's a lot of the clinical work.
Well, our time has come to a close. I want to remind people who have tuned in that we will be together again October 13th, also a Tuesday at 6 o'clock. And we're going to be looking at the mental health of a group I'm very familiar with, boomers. And I learned from my grandson that is not a compliment to be a boomer. But we're going to be talking about boomers who often really are not focused on in terms of mental health. And so I want to thank the three of you for being with us tonight. As always, I learn from each of you. And I think we have a lot of to-dos that we can start doing right here at Columbia. So thank you very much and good night.